not having that knowledge medically within the medical system and therefore not allowing a child to get the support it needs will also mean that the parents won't be aware that this is an issue. And that means that their relationship dynamic, the way in which they interact with the child, will be different than if they understand that there is a different neurodevelopmental condition that explains the why behind behaviours.
Welcome to All Aboard, where we help parents navigate the ADHD journey. Whether you're at the beginning of this journey asking what now, or you've trodden this path for a while and are wondering what's next, All Aboard ADHD is here for you. We will bring you key information from expert interviews, inspiring special guest stories, and parents sharing their real-life lived experience to help you feel less alone. I'm Claire, and today we'll be talking about ADHD and coexisting conditions with our expert guest, Professor James Brown. James is the co-founder of ADHD Adult UK, a registered charity supporting adults with ADHD, and one of the creators of the ADHD Adults podcast. Diagnosed with ADHD in adulthood, James brings both academic expertise and personal insight to his work. He is also the co-author of ADHD Unpacked, which provides a practical and honest guide to understanding ADHD in everyday life. James is a visiting professor in science communication at Aston University, and he also co-founded focusmag.uk, a free online magazine offering accessible, evidence-led content about ADHD, and has written widely about health and neuroscience. His articles on the conversation have attracted over 3.8 million readers. A frequent speaker and media contributor, James appears on radio, TV and live stages across the UK. He is also an ADHD coach, consultant and science communicator known for combining scientific accuracy with warmth, honesty and humour. Welcome aboard, James.
Hi, how are you?
I'm good, thank you. Thank you so much for joining us today.
That's my pleasure.
So we are going to talk about ADHD and coexisting conditions. So let's start by asking, what do we mean by coexisting conditions or comorbidities, to use the horrible official word, when it comes to ADHD?
It's a really good question. Particularly the use of morbid in comorbidities, because people think of death, but biologically or medically it means illness. And a coexisting condition is a condition that occurs alongside another condition, not by coincidence, but because they often share underlying genetic, neurological, biological or hormonal pathways. So in the case of ADHD, it's normally the genetic, neurological or developmental pathways. So a coexisting condition that's very common in ADHD, for example, might be an anxiety disorder or another neurodivergent, because they both involve the brain and the central nervous system. So it's an extra condition that's there at the same time, but not by chance, if that makes sense.
Yeah, it does make sense. Really interesting. As you say, it's not by coincidence. So given all of those connecting factors, like what percentage of children with ADHD have one or more coexisting, co-occurring condition with ADHD?
It's a really good question again, and it's probably more than people think. So whenever you look at research around these things, you'll get a range of percentages, because different studies of different sizes show different things. But you're looking at about 60 to 70% of children with ADHD that will have at least one coexisting condition. And then when it gets to two or more coexisting conditions, it's as high as 40%. So we're talking about the majority of children with ADHD will have at least one coexisting condition to deal with alongside their ADHD.
Which is so interesting, because actually perhaps not diagnosed yet in many cases, because that's exceptionally high, isn't it? It's almost the norm in that sense. And what are some of the most common coexisting conditions that show up in children with ADHD? Because you touched on anxiety there, but there's many, aren't there?
Yeah, I mean, if you look at ADHD in general, but particularly in children, then the thing you said actually just before is so important. The lack of diagnosis skews the data, because, for example, almost everybody with ADHD probably has dyspraxia or developmental coordination disorder, because if you look at the diagnostic criteria, 2/3 of them are exactly the same. It's about internal organization and about motor skills. So another neurodivergence, whether it's autism, whether it's dyscalculia, a developmental coordination disorder, they're very common. But anxiety disorders, might come out on top. Now, in children, that can manifest itself in a number of different ways, but it could be social anxiety, it could be generalized anxiety, particularly separation anxiety, being away from parents or home or a phone. But there's stuff that lots of people don't really know about when it comes to ADHD, like sleep disorders. It's very common in adults and in children that there is either poor sleep quality, insomnia, delayed sleep onset, or specific sleep disorders like restless leg syndromes. And then, the list, it goes on. Mood disorders like depression, tic syndromes such as Tourette's. There are lots of largely neurological conditions that do show up. The last one I'll mention, because I think it's important and very common, is oppositional defiant disorder. It's not a term that I like personally, but it obviously does describe a behavior pattern. And if you like, is really a subset of being neurodivergent as opposed to a coexisting condition.
I'm sure everybody listening will be able to relate to the sleep one as a parent, if nothing else, because I feel anecdotally from obviously my own experiences, but any parent I've ever worked with, anyone I've ever coached, that sleep is a completely common challenge of ADHD. And actually, I've never really thought about it as a coexisting condition before. So that's really interesting. And something you touched on there, I just wanted to understand a little bit more about, is that you talked about the way in which, this, so you said earlier on, it's not a coincidence, but the way in which a lot of these traits cross over. The example you gave was dyspraxia. So if ADHD is sharing a lot of traits with these other coexisting conditions, how can we begin to tell the difference between them?
It's such a pivotal question, largely because the tools that we currently have to diagnose individually these neurodivergent conditions aren't very good. And it means that, the questions that are asked, the observations that are made will often only focus on one neurodivergence and will discard or exclude signs of a second or another neurodivergence. The reasons that they often exist is there are overlapping biological systems. So the parts of the brain that develop differently in ADHD are often similar or the same to the parts of the brain that develop differently in autism or in DCD or dyspraxia. And therefore, that shared, if you like, biological basis is what then manifests in symptoms that cross over quite a lot. And this is something that's so challenging because, as I said, if you look at the diagnostic symptoms for dyspraxia, it looks a lot like ADHD. And therefore, a child who might be picked up for dyspraxia because in their school, that's something they're more aware of, might not also be assessed or investigated for ADHD. That overlap is really challenging. The approach should be, let's look for all the neurodivergences because we know that they coexist, but it's often, let's look at one and exclude all the others.
That's such a good point. I think we'll come back to that in a minute if we can, because I think that's something that needs to be discussed in more detail. But on the subject of those kind of crossovers, you also touched on things like mood disorders and mental health conditions, things like anxiety. So why are they more common when it comes to ADHD?
Again, I keep on saying it's a great question, Claire, but that's because you ask great questions. It's partly biological, partly social. So, for example, if you look at anxiety disorders and the biology, if you like, of anxiety, there are parts of the brain whose role is to detect threat. So there's a part of the brain called the amygdala, and the amygdala is there to perceive threat from something. And the amygdala works with a part of the brain called the hippocampus, and that adds context. So if the amygdala picks up that there's something negative, fear or anxiety, etc., the hippocampus will often say, it's okay, you're at home and you're watching a scary film. So it's not really scary. And then another part of the brain, the prefrontal cortex, which is where most of our higher level mental skills are, will be connected to both of them and will, in biological terms say, it's okay, everything's fine, there's no need to panic. Now, in ADHD specifically, all three of those parts of the brain are slightly different. They're often different in terms of their size, their structure. They're different in terms of their connectivity and their function. So if the part of the brain that triggers a kind of a danger signal is overactive and can't be if you like, dampened down by other parts of the brain, that will lead to a state of anxiety. For mood disorders, it's a bit more complex. There isn't as much research in terms of even what the causes of mood disorders are. I'll give you an example. Very recently, there's been a paper that's come out that suggested that everybody that has a mood disorder should be assessed for inflammation in the brain, because one of the latest theories around depression and other mood disorders is it's an inflammatory mental health condition. But we don't really understand that yet. So for some coexisting conditions like anxiety, it makes biological sense. And for others, such as mood disorders, it could be that it's related to the challenges of living as somebody that's neurodivergent, getting negative feedback or being criticized or feeling different that can lead to a mood disorder.
That, I think, is the best description I've had about the relationship with anxiety and ADHD. The way you just put that across, I thought was amazing, because obviously we know there's a very common link there, and it's something that, again, we can all relate to in some degree or another. It's certainly something that I hear a lot about. And we know, I certainly do, as someone with ADHD, I'm overthinking all the time, but actually putting it that way in all those different parts of the brain when they're acting almost simultaneously, unable to quieten the other down, makes so much sense. Because I've heard people almost even suggest that ADHD and anxiety are so closely linked that often if you are not aware that you have ADHD, but as someone that is struggling with anxiety, that perhaps you should look even further because of that very nature.
It's one of the, if not the most cited reasons that somebody first goes to see a GP or a healthcare practitioner is anxiety. And sadly, because the level of professional education for many people in healthcare isn't maybe where it should be, the immediate response would be, okay, well, here's a tablet for anxiety and take it and see what happens. Not, let's ask some questions and dig deeper. What's the cause of this anxiety? And that's largely because, under-resourced, lack of time, etc. But absolutely that anxiety being seen as the first issue that leads to engaging with the healthcare system is very, very common.
So interesting. And also the paper that you mentioned in terms of inflammation in the brain linked with mood disorders, I thought that was fascinating too, just because I happened to have a conversation with a consultant last week. It wasn't in relation to ADHD, but she was talking about the way in which they have seen on brain scans inflammation markers with people who don't exercise. So it can actually show up in your brain. And we think about exercise in terms of, one, obviously, vanity, how your clothes fit, but then there's the elements of maybe your cardio health, keeping your organs healthy, and we're becoming more and more aware of the links from a mental health perspective. But I thought that was so interesting that they can actually see on a scan those inflammation markers from people that haven't exercised versus that they have, and made me think about something that Dr. Alessio Bellato was saying on a recent episode we did on emotional regulation, and he was talking about the very, very positive and strong impact that exercise has on emotional regulation, which I guess, and I'm not an academic, but I'm just thinking in kind of full circle sense, you can imagine why then that inflammation would be linked to being visible in kind of mood disorders as well.
Yeah, it's interesting because we've known for a while, we as in the scientific community, that the reason we thought antidepressants worked isn't the reason we thought. So common antidepressants that, for example, target serotonin, it was thought increase serotonin, that increases mood. And actually, in the last couple of years, there's been a lot of progress to show that it might not be that. And actually, it might be that those antidepressants are decreasing inflammation, or that they're not having much of an impact itself, and it's other changes that have an impact. What makes it really fascinating for me as a biologist is that people with ADHD are more likely to have immune issues. So whether that's autoimmune disorders, whether that's overactivation of some immune cells, such as mast cell activation syndrome, that's more likely to happen in ADHD. And that could be, if you like, a biological driver of inflammation in the brain. The exercise thing, it's so important. It is probably the most powerful pharmacological or pharmaceutical approach. We know it increases focus during a bout of exercise, after a bout of exercise, improves emotional regulation, improves many of the symptoms of ADHD. But obviously there are so many challenges in terms of the executive function that's needed and the motivation that's needed to exercise for some of us. So absolutely it's possible that exercise is impacting inflammation as well as kind of changing dopamine levels in the brain.
And you mentioned then about anxiety and ADHD, that often it's the first thing that takes someone to visit their GP in the first instance. So why do we often hear stories of people with ADHD initially being misdiagnosed? Kind of stopping there, if you like.
Yeah, there's several reasons. First of all, again, the lack of appropriate understanding and knowledge within the healthcare profession. I hear all the time from people who get in touch either to the charity or the podcast that they're told by a GP you can't have ADHD because adults don't have it, or you can't have ADHD because you've got a degree or a successful career. So even if it gets to that point of discussing it, there is often a barrier in that case. Probably the bigger problem is the fact that ADHD presents like lots of other things or crosses over with lots of other things. So we know that it shares similarities with anxiety disorders because people with ADHD often have what we call mood instability. So that can be within a day, going from really happy to really sad, or within a couple of days, that it can present a bit like a mood disorder. We know that it has symptoms that are very similar to what used to be called borderline personality disorder. It's now emotionally unstable personality disorder. It has similar symptoms to PTSD. It has similar symptoms to other conditions. And if those other conditions are better understood by the practitioner, it's more likely that they will be biased. And everybody has bias. We should all acknowledge that. But if, for example, a practitioner's bias is that trauma related, they are probably more likely to say, well, I think this is, a response to trauma, rather than let's go down the route of looking at ADHD symptoms. So there's a lack of understanding in clinicians, but there's also the fact that ADHD has and shares symptoms with lots of other conditions.
Yeah, because we're not yet looking at that big picture then in all those senses. Because I was thinking also about children and some learning differences. So, for example, a very common one that seems to be the case is a child gets an initial diagnosis of dyslexia and then nobody looks beyond that. You kind of got that, okay, everything is in theory explained by the dyslexia, except it's not. So how common is it that in fact there are likely to be other things going on like ADHD in the background? Very
short answer. Longer answer is that often once a satisfying, in inverted commas, diagnosis is made, some healthcare professionals or educationalists can stop asking questions. Well, we've got a diagnosis now, we know what the issue is, and there we go. But obviously with many children and adults, dyslexia may come alongside autism or ADHD or other neurodivergences. And unless that's identified and looked at, then the child won't get a complete support package. We need rather a yes and mindset, not a this or that. And that's a big issue within psychiatry, whether it's child psychiatry or adult psychiatry, is once a diagnosis has been made, it can sometimes pigeonhole a child or an adult. And therefore, just changing how we look at neurodevelopmental conditions to be, okay, this child has dyslexia and what else? Rather than this child has dyslexia, so it's probably not anything else, would be a much healthier way of making sure that we get the appropriate support in for the various diagnoses that a child may have.
And what are the risks if we don't? If we do stop at that initial diagnosis and we don't look beyond that, and therefore, yes, there's support in place for one element, but perhaps not the whole picture. What are the risks to the child and obviously beyond into adulthood?
If we look just at ADHD, if we use that example, let's say a child is diagnosed with dyslexia and support is put in place throughout educational experiences and later on in the workplace just for dyslexia. That means that you're going to have what we would call the typical, if you like, late diagnosed ADHD adult. And that often means somebody with low self-esteem, somebody who's had issues with employment, with education at different levels, with finances. Missing the opportunity to put in an intervention that helps the other diagnosis, in this case ADHD, means that person is likely going to have what we call negative outcomes. The benefits of whether it's medication, whether it's support in school, whether it's access to therapy, for example, are proven. And we know that, pretty much every outcome, educational, employment, relationship, is improved with early diagnosis and treatment. So by missing that, you're consigning a child to have a more challenging future.
And on that then, because you touched on this earlier actually, and you were saying about clinicians and the natural biases that we all have, even my bias, right? This is an ADHD podcast, so mine is kind of explicit there in that sense too. But why do you think then that kind of the education, these conversations, raising awareness is so important when it comes to really understanding ADHD and its wider coexisting conditions?
It's fundamentally important because knowledge, first of all, empowers the patient or the individual to get support. That lack of knowledge is a barrier. Like I say, we hear all the time that those barriers are systemic. Within multiple levels of healthcare system and education, barriers are put in place, often because of a lack of knowledge. But if we go beyond that, increased knowledge reduces stigma, it builds compassion. It helps people who work with children, particularly in a school setting, to understand the why behind behaviours. It means that can then allow them to better support the how of helping. If you know the why of the behaviour, then the how of helping is going to be different. And I think it's also fundamentally important because that knowledge will mean that parents are better equipped to advocate for their child. Not having that knowledge medically within the medical system and therefore not allowing a child to get the support it needs will also mean that the parents won't be aware that this is an issue. And that means that their relationship dynamic, the way in which they interact with the child, will be different than if they understand that there is a different neurodevelopmental condition that explains the why behind behaviours.
Yeah, it's very true, isn't it? Like often people say, maybe thinking about in relation to myself, because I had a later adult ADHD diagnosis following my son's journey, and then maybe they're talking about themselves and asking, well, what's the point? It won't really change anything. And it's that for me. It's the ability to perceive things through a different lens, to really understand yourself, have that compassion, and then when it comes to your children, as you say, advocate for them, and to help them understand their own brain too. That how and why thing that you talked about, I think, is such a great way, very simply, of boiling the essence of why this is so important down. And in many ways, it's why I started this podcast, because I felt very, very alone at the beginning of my journey, and I kind of coped by learning. But I appreciate not everybody has that capacity for whatever reason, and I just felt so strongly and so passionate about helping to be part of a solution so that we could help raise awareness, and in many ways not just for our children in terms of our advocacy for them, but I also think for their understanding of themselves, so that we hopefully get to a point where this next generation coming through have a much more accepting and inclusive understanding of these elements, and that it changes things going forward. It feels like it's being part of a solution in many ways. But for those children that are struggling then, and for parents that are listening, perhaps they have an ADHD diagnosis, how can parents tell if something else might be going on? When should they consider looking beyond ADHD, and why is that important?
It's challenging, but it gives the opportunity to point out something that's fundamentally important, and that is that we are diverse as a neurodivergent group. Children and adults, we aren't all the same. And we all present with slightly different symptoms, slightly different traits. Some people are more hyperactive than others, differences between boys and girls. So it sometimes is challenging to know if there is something else. The easiest way, and it doesn't always work, but it is the easiest way, is that if a child has been diagnosed and is receiving treatment, but is still significantly struggling in other areas. So that could be emotionally, it could be socially, it could be academically. Then it might be time to consider, requesting additional assessments. Parents know their children better than anyone. And one of the things I find most frustrating is when I hear anecdotes of children who get assessed, and at home, the home report is, yes, this child is definitely ADHD. But then the school report, because it's a structured environment and because particularly girls will be more internalized and daydreamy and not disruptive, the school report will say, no, they turn up on time, they're performing okay. And then that child won't get a diagnosis. Nobody knows their children better than their parents. Trust your instincts. If something doesn't feel like it fits the ADHD picture, then ask if you can dig deeper.
Such a good point, isn't it? And that's definitely my experience with my own daughter. She's 9. She was diagnosed about a year ago, not long before her 9th birthday. And I was kind of between a rock and a hard place when I was going through that process with her, because one, I was trying to be very careful not to make the shoe fit, even though I felt like I'd been seeing so many signs for such a long time. And at the same time, without that knowledge and awareness, she would absolutely have been someone that slip through the cracks for that reason. Because whereas my son, diagnosed at 6.5, very hyperactive, bouncing off the walls, you couldn't miss those externalized expressions. Whereas my daughter really internalizes it. She doesn't struggle at school. She's a people pleaser. She masks more, but being at home and in other scenarios is a completely different picture. And it does come down to that dual environment thing, doesn't it? And I heard, I think it was Professor Susan Young that said, it doesn't need to be home and school. People often think those are the only 2 environments that children exist in, and they function in so many other places. So think outside of that. Where do you see your children have these challenges, and then focus on that evidence?
I am so glad you said that. One of my colleagues and a fellow trustee of our charity is a psychiatrist, and we've chatted about this because it is almost exactly that. Those, as if the only 2 domains of a child's life are home and school, and they don't consider sleep or socialization or self-care or emotional control. They're all domains of a child's life, and they should all be considered. So if a child is doing okay at school, they're not disruptive, they tend to turn up to lessons, their performance is okay, that shouldn't exclude ADHD. If at the same time they're not sleeping at all, or if they are struggling to socialize. And that concept actually that children have multiple domains to their lives should be central to the way in which we approach ADHD in children.
Yeah, so where are you seeing those challenges, and then build your evidence, I guess, around that. And as you say, if you've already got an ADHD diagnosis, but they are still struggling in those areas, then perhaps that's the time to look beyond it. And what about some of the kind of lesser known conditions that show up alongside ADHD? You mentioned oppositional defiant disorder at the beginning, and I'm kind of thinking like sensory processing, demand avoidance, social anxiety, RSD. What should parents be aware of when it comes to those elements?
I mean, exactly those things. Interestingly, the list of non-diagnostic symptoms, in my opinion, is often more challenging than the diagnostic symptoms, which are largely about attention and hyperactivity and impulsivity. But other things to look out for, you mentioned sensory processing differences or disorders. So this is more commonly associated with autism, but it's very common in ADHD. It can affect how a child eats. It can affect how a child dresses. It can affect how a child responds to certain environments, if it's too light or if it's too noisy. I can give you a personal example. I have a lot of shame about this, but I cannot eat foods that are cold, crunchy and wet, which basically means vegetables and fruit, because the texture, it causes me distress. Now, if it's all blended up into a soup or a smoothie, absolutely fine, love the flavour, and the texture is different. So that's a big thing because it can change the diet of a child. It's the same with the clothes. I hear quite often about children who, for example, struggle wearing shoes and will take them off at school and will then be admonished for taking their shoes off because, that's not the norm. But if it's causing distress, you can understand why a child would take the shoes off. Demand avoidance is actually a central part of ADHD. And again, it's often more associated with autism. And your listeners may have heard of pathological demand avoidance. Again, a name I hate. I prefer extreme demand avoidance because a lot of demand avoidance actually comes from anxiety. And calling it pathological takes away the autonomy of the child to be avoiding a demand because they're anxious. And demands aren't always external. So the obvious example of a demand is, come on, get dressed, it's time for school. But demands are also internal, making a decision, committing to doing something, considering options. They're all mental demands. And therefore, noticing if, a child that has ADHD can look defiant, so look a little bit like oppositional defiant disorder, actually can often just be about control or overwhelm, leading to avoiding that demand. Social anxiety, I have social anxiety disorder, and it is pretty much the same as rejection sensitivity. Social anxiety often people think it's about being in crowds. I'm anxious when I'm in crowds, but it's actually about being in crowds when you're being observed and you think you might be judged. And therefore, when you go to school, for example, if you're in a class where there are some people who've made comments in the past about you, or, pick on the fact that you wear different shoes, etc., that can lead to social anxiety disorder or make it worse, because the fear is, well, I'm going to go into that environment, they're going to observe me and they're going to judge me. And that's pretty much the same as rejection sensitivity, this idea that I'm being judged, that judging is negative, and that leads to the intense response to kind of perceived or real criticisms or rejections.
Oh, I could relate personally to every single one of those examples that you gave there. Firstly, I thought the example you were talking about with your food, and you said you have a lot of shame around it. And I think, isn't that so sad? Because this stuff comes from judgment, and often in childhood, as you then went on to talk about from a social anxiety perspective. I had a similar thing. I was communicating something on behalf of my son just yesterday, actually. He's 14 and he's going to be doing something for school next week that will take him into a different environment and with a teacher who knows him, but perhaps not really aware of his needs. And I had to put some information to an email. One was the fact, because they'll be staying overnight, that about his eating, he eats very plain, very simple food. And please, could that be supported with kindness and not, ridicule? Because that has a massive, massive impact, doesn't it? Demand avoidance, I see that so strongly in my daughter. And then the RSD element, the judgment thing, that's me. So those three examples, they resonate really, really deeply with me on a personal level. And I'm sure people listening too.
They're pretty universal, really, aren't they? And I think that, again, that guilt and that shame is a big part of this, because many people who don't get diagnosis and support as children will grow into adults that live with constant shame, thinking, I am that thing, not I did that thing. I am useless. I am lazy. I am unreliable. And one of the things that I often get asked, and this is, I suppose, a controversial and personal area, is there value to giving a child a label, for example, of ADHD? And my response is normally, it's better than the labels I give myself. That for 40, 50 years, I've given myself all these labels of being useless, thick, unreliable, flaky, etc. And they've stuck with me. They're deeply entrenched into my identity. And that means, for example, when I go to a restaurant and order a burger, the shame I feel when I say, can you not put any salad on it, please? And I feel like a child. I feel like an 8-year-old that's saying, no, I just want the burger and the baps. It's silly because it's a normal request. They probably get it all the time, but the shame I feel by just saying that is very real as a 50-year-old man.
Yeah, I 100%. I could not agree with you more on everything that you just said there. I think that labels can be used very positively and very powerfully, and can help counteract some of that negativity and shame that we will otherwise build up. That statistic that, children with ADHD, by the time they're 12, have received 20,000 more negative messages than a neurotypical child. And the impact that has on someone's self-esteem, sense of self, their self-worth, is crippling. I think that's definitely probably the biggest area in my life I've struggled with, for sure. And so we're hearing more about emerging conditions with their connections between ADHD, coexisting conditions that might be there, like asthma, histamine, sensitivity, hypermobility. Is there any evidence here, or is this kind of still early days?
There's actually lots of evidence, but it's not causative. So it's correlative. What that means is, if you look in a group of people with ADHD, you look in a group of people without, we find higher rates of asthma, higher rates of histamine sensitivity. The histamine receptors in the brain, for example, are probably important. Higher rates of hypermobility and Ehlers-Danlos syndrome as a manifestation of hypermobility. Higher rates of migraine. Higher rates of hypothyroidism. And therefore, what we know is these things, again, co-occur with ADHD, but we don't really know why. There is some evidence, for example, with hypermobility and weirdly migraines, that it could be that a protein in the body called collagen, which helps form the structures around blood vessels, forms slightly differently, and that collagen also forms things like tendons and ligaments. So therefore, that could be the reason that some people with ADHD have hypermobility or chronic migraines. But it's very early days in terms of the why, or in terms of the direction. So what is it about a brain developing differently that leads to asthma, for example. That's the really interesting bit that we don't know yet.
I have asthma, so I'm very keen to learn more about that. And actually the histamine element of it, when I think about my son as well, because he has rhinitis. So I'm genuinely really fascinated by all these areas and learning more as the kind of evidence emerges. But I thought it was interesting what you said, that it's correlated. So it's linked, but it's not a cause. Can you just explain a tiny bit more about what you mean by that?
Yeah. So for example, if you look, I'm going to give you a really weird example now. If you look at the first ever study into smoking and lung cancer, what it reported was that drinking excessively causes lung cancer. And that's because they looked at a number of factors. And one of those factors was units of alcohol consumed. And there was a statistical link between alcohol consumption and lung cancer. But alcohol consumption doesn't cause lung cancer. So it's a statistical link and nothing else. We know now that smoking causes lung cancer. So that is a causative factor. If you smoke, you are more likely to have lung cancer in a much higher rate than if you don't smoke, for example. So if we knew that the brain developing differently in ADHD led to histamine receptors, for example, developing differently, that would be causative. At the minute, we don't know. We know they occur at the same time, but we don't know if one causes the other, if that makes sense.
Or just there's a commonality, because I might have misunderstood what you're saying there, but I guess thinking back to when that evidence emerged and people were smoking in pubs as well, if you're smoking, perhaps there is a likelihood that you're also drinking more, and that you're in those environments where the two things at that time would have gone hand in hand. So in theory, if I've understood what you're saying, you can see how there is a correlation, but not that necessarily one is caused by the other. Have I understood that right?
Exactly that. And what you've talked about there is a confounding variable. If something else, which can look like it's causative, but yes, if you can prove that one thing causes another, and that's often challenging because it needs a different type of science, then you know that it's causative. If you observe a mathematical or statistical link between two things, but it's not obvious that one is causing the other, then that's a correlation or an association. So, for example, and this is literally true, there is a correlation between Nicolas Cage films and people drowning in swimming pools. Now, that doesn't mean that Nicolas Cage films lead to that, but if you track years that his films have been released and you know that terrible thing happening, there's a correlation. They're obviously not linked, but there's a weird mathematical thing going on in those years that happen. And that tells you that sometimes reading a paper or hearing something scientifically that says, oh, this has been linked to that, you have to be a little bit skeptical.
What I love about that is who thought to check that those two things were in any way related? That would be my first question. Why did that pop into someone's head? I wonder if. So yeah, well, you talked about drinking then, and I think that's kind of an important one, because I just wanted to ask you a little bit about the risk of things like substance abuse if we think about kind of teenagers and young adults, and how does that connect to existing conditions and perhaps even unidentified or unmanaged ADHD earlier in life?
So if you look at all the big population studies, that people with ADHD are more likely to have a substance use disorder, whether that's alcohol, whether that's cocaine, whether that's cannabis, for example. We are also more likely to have what used to be called addictive behaviors. So that could be mobile phone addiction, porn addiction, gambling addiction. We don't tend to use addiction as the word in the diagnostic frameworks anymore. But what we know is that there are biological and social reasons for this. If you combine the impulsivity that many children with ADHD have, that means they often get exposed to a substance earlier. Rather than saying no and thinking through the consequences, more likely to say, yeah, okay. If you think about the people-pleasing / peer pressure side of being a teenager with ADHD, and you've got the cool friends saying, hey, have a drink when you're 14 years old, you want to fit in. You want to be like them, and therefore it's more challenging to say, no, actually, I'm going to wait until I'm old enough to drink. Then we have the really deep biology that's important. Lots of different parts of the brain develop differently in ADHD, but the part that's probably most important and different in terms of our behaviors is the reward center. And that's the part of the brain that when we're exposed to a person, a substance, a situation, an event that we associate with a positive outcome, it gives us the motivation to do that again. And our reward system, which is very much driven by dopamine, isn't as functional or isn't as typical as people without ADHD. So what that means is if we are more impulsive and more likely to get exposed to alcohol or a substance, and then we get a big release of dopamine, that will reinforce and give them motivation to do it again. And that means that you get early exposure, repeated exposure, which can then lead to substance misuse. So there are kind of biological and social factors that effectively create a perfect storm for increasing the likelihood of having issues with substances.
And I'm just thinking, in terms of all the other elements that we've been chatting about today, about things like self-esteem, about focusing kind of on strengths and helping our brains and our children's brains move away from some of those negative thoughts and that shame and that judgment, and trying to, I guess, help them learn about themselves. We talked about that kind of positive labeling so that they can understand the why behind some of their behaviors. And then hopefully as they evolve, this is something I work on when I'm coaching like tweens and teens, in terms of that pause, starting to identify and learn to put it in place. And then I guess crucially, from a reward center perspective, if we can lean into interests and we can help develop those, then maybe we can start to put in more positive rewards that our brain looks to naturally, like exercise. We kind of touched on that as well, didn't we? That we start to replace some of those decision-making choices as we get older with, when we're kind of going into those years when maybe there's a much higher risk at play, which I guess leads right back to this sense of why it's so important to understand and identify this stuff as early as possible.
100%. I can tell you now that if my earliest inclination I had ADHD was back in 1983 when I was 8 years old. And I remember the GP saying, he's hyperactive, Mrs. Brown, but don't worry, he'll grow out of it. Now, back then, you couldn't be diagnosed on the NHS. In fact, you couldn't as a child until 2000. So it didn't, if you like, exist in the UK medical system. But I know if I'd got that diagnosis and support, my life would have been very different. Now, I'm actually kind of happy with where I've landed because I'm lucky to work in the field of ADHD and to try and help the next generations. But all of the mental health issues, the deeply entrenched low self-esteem, the negative self-talk, the substance use, all of the things that have been my life could have been different if I'd had that access to support when I was younger. And whilst I don't regret much and I don't kind of grieve for what might have been, I do hope that the latest or the following generations get the chance to have that different life.
Oh yeah, me too, completely. I think it's just understanding yourself through that lens, isn't it? And some of those examples you gave were of me, at 14, some of those choices I made because I so desperately wanted to be accepted and to fit in, because I've had this kind of low self-esteem, low sense of self-worth, of not being enough, that's been forever present. And just understanding myself that way now, even though I wasn't diagnosed till I was 41, has been so revolutionary to me. And I feel like I'm still, every day, the more I learn about ADHD, the more I'm actually able to relate it to myself and go, oh my God, that's why I did that, or I do that. I've never thought about it that way. So it's a kind of constant process, but I think it's a really important one. So what final piece of advice would you like to leave parents listening to help them feel less alone on this ADHD journey?
First of all, it may feel isolating, but you're not alone. There are many parents who are going through a similar situation, and therefore looking for support, whether it's online support groups, local support groups, resources on charity websites, can at least help you feel like you're not going through this alone. Secondly, it's probable that you're not imagining this. It's probable that if you're observing these behaviors, and particularly if you yourself are neurodivergent, that this isn't a figment of your imagination. ADHD is very complex. It's very complicated. Your child, if they're struggling, those struggles are valid, even if they don't fit the very outdated, very white boy-centric tests for ADHD. So particularly if you have a daughter that you suspect has ADHD that isn't, doesn't fit the profile of the typical boy with ADHD, it doesn't mean they don't have it. Trust your gut. Ask questions when you get the chance to, and try not to settle for partial answers. The coexisting conditions thing doesn't mean, just like ADHD, that something is wrong with your child. Being neurodivergent isn't bad. Being neurodivergent isn't wrong. So accepting that different is actually good can really help when it comes to understanding and supporting your child. And it means you can understand, if you like, the whole child better and not just the behaviours of the child.
Difference is absolutely good. Thank you so much for finishing on that really positive message. I think it's an important one that parents really, really need to hear, that these are all really positive things. And when we focus on understanding our child and moving away from the shoulds and kind of just doing things differently in line with our intuition and our gut for what they need, then we can really start to change the narrative here. So thank you so much for joining us today, James.
Honestly, it's been a pleasure. Thank you for having me on.
If you'd like to learn more about ADHD coexisting conditions and related issues, then please do check out our show notes below for more information. Or if you'd like to find out about how I can help support you and your children with personalised ADHD coaching, then please do head to allaboardadhd.com. You can also find me on Instagram and TikTok at All Aboard ADHD. Most importantly, if you enjoyed this episode and found it helpful, please can you follow and review All Aboard to help other parents find this podcast and welcome them aboard our journey too. Thank you for listening to All Aboard ADHD.